Thank you very much, Gertrude, for that wonderful presentation. I think I would like to take this opportunity, first of all, to sincerely thank the 6 presenters here. And I thank you for 2 issues. The first one, I personally requested you to prepare these presentations, and you graciously agreed. So thank you very much, and I do that on my own behalf, but on behalf of the HIS project and the AAVP. But secondly, I really want to thank you for excellent presentations. I think all of you have really opened our eyes when it comes to the problem of HIV in adolescents in Tanzania. And to me, certainly, we have a serious problem before us. 2030 is not very far, but the problems are really big. So I don't know, where did we go wrong? Are the strategies that we have adopted not working? Is Rahma right that whatever we have been doing, we have not actually included the beneficiaries themselves, right from the planning stage to the end stage of what we wanted to do? And therefore, I would like to break the ice by asking Evelyn, with all this that has been presented today, and I know the permanent secretary is also here, whether the ministry now will be in a position to rethink the strategies that this country is deploying to address HIV in adolescents. I think we have had very good evidence here. We are not at all doing well when it comes to HIV in adolescents. So this panel discussion now is open for people to comment. We do not have a lot of time, but I think this is a very, very important issue that we need to discuss. But in view of the time constraints, maybe just a few comments from the audience. But also I would like to let you know that in the HIS grant, in the HIV Implementation Science grant, we are also planning to have a session where we are going to deliberate specifically on HIV in adolescents in this country. So we will have another opportunity as well. But may I welcome the audience to contribute to this excellent work. Yes, I can see 2 hands there. So atakayesimama ndo wa kwanza. Atakayesimama kwanza ndo wa kwanza. Good. Karibu. Introduce yourself, go to the point, and target the presenter that you want to respond.
I'm Elizabeth. I'm with MDH. With the emphasis on mental health over the recent years, we have heard from the panelists how all these interventions have been adopted and yet we're still struggling. How we looked at the prospect of including pediatric psychologists to try and bridge the gap between the current information that we have, evidence that we have that this can work, and actually relaying that information to the beneficiaries, as Rahma emphasized. But we are also looking at another group, that is the parents who are caregivers or other caregivers who are working with adolescents with HIV. How are we trying to help them to understand the disease? And psychology is a huge part that needs to be addressed.
Okay, and your question is directed to?
All the panels. Whoever is ready.
No, pick one.
Evelyn, would you help us?
Exactly, Evelyn, yes.
Can I take another?
Yes, Redempta.
Thank you very much to all the presenters. Very exciting presentation. My question goes to possibly Evelyn again, and some of the researchers here. So, you know, one of the key barriers that really prevent us from reaching the epidemic control we are talking about is structural barriers related mainly to the political environment. We have very good guidelines, we develop them together, but we know that if we don't provide equal or even more access to the vulnerable population, the key population, including female sex workers, MSM, and so forth, we will not end HIV epidemic because they are part and parcel of the community. So for us as researchers here, how can we actually use research to understand first, why is it a problem to accept for those who make decisions? I think it's time not to just complain and blame, but really to do a research to understand why is it, and if there is any preference of conducting, the research should also try to understand what are the best ways of providing access to these populations, so subpopulations, so that we really make sure we control the epidemic. Thank you.
Thank you, Redemptor. And Professor Fauzi?
Great, really excellent presentations, all of them. And there are many questions, I'm sure, in the audience, but one that caught my attention is Dr. Miriam noted that males have higher mortality, if I remember, and Dr. Gertrude, that males are less likely to have viral suppression. So if you could comment on why that is the case and what can be done.
Okay. There was a hand there. Sijui umeinua mkono wa kushoto. Sikuoni vizuri. Haya, huo wa kulia sasa hivi. Inuka basi. Yeah.
Okay, thank you very much. Especially, my question goes to Gertrude. I think we talk about the viral suppression and adherence, though we try to take it as the measure of the adherence to viral suppression. So I find it to be like a proxy because there are so many ways. Somebody may be adhering to drugs, but the drugs are not working. So part of the study, I was just thinking, is there a possibility of looking beyond that, beyond somebody having the viral suppressed, but they might be having other factors which are attributing to they might have a good adherence, but they are poor viral suppression. Yes, sir.
Okay, can I ask nadhani the panelists should respond to whatever has been asked. Maybe some of the prospective questions would be answered. So can I start with Evelyn?
Okay. Thank you, Professor, and thank you all who asked the question. I expected most of the question, especially the one saying why don't we involve the pediatrician and the other psychologist, yeah, on the issue of tackling the challenge of HIV to AGY and the other adolescent groups. Starting by, I can say the government has worked a lot on the issue. If you remember, before this data that I've explored today, the AGY was, those who knows their status was below that. So after lowering the age of consent, at least now we have improved. Apart from that, also the government currently now, the Minister of Health, has developed the accelerated plan for case identification to adolescents and youth and children. This one will help. I remember even 2019, we had the same challenges on the first 90. At that time, we were working for first 90. But after having the accelerated plan, it helped a lot until I think most of us will remember how far we went to the first 90. So with this forum, I also like to inform you there are efforts that the government is working on it, and the comment of involving other stakeholders, including the pediatrician, is well taken. Although we have this TWG, Technical Working Group, where we involve all the stakeholders, including pediatrician, psychiatrist, and so far. So the comment has been taken, and I think for the case of this meeting, maybe this symposium, it's also the area for research. Maybe I can encourage we scientists to take this and gap for other research or other study, so that maybe we can get more causes of these challenges for the AGY and the other children. It's the same to the children, to adolescents. Maybe we can take it as an area of research. Coming to another question, someone asked, Dr. Florence, I think, asked about the structural barrier that, Dr. Mbatia, okay, sorry. Asked about the structural barriers, that it's time to remove these structural barriers that interferes with the health service for the key and vulnerable population. I can declare interest with the coordinator of key and vulnerable population. We know we worked a lot. The government accepted that approach of public health. We do work, we have the forum for key and vulnerable population, but we mostly working with the groups that we did the research. We have the data that inform their risk of behavior towards the HIV. Maybe also it's the time to look for other groups of the key and vulnerable population to see their risky behavior related to HIV, yeah, so that we can have a big number of people who knows their status, especially key and vulnerable population. Thank you.
Mariam?
All right, thank you. I was asked by Professor Wafai on why high mortality among males. So there is some data that I didn't project, but in my study when I was looking at the baseline characteristics, compared to females, most of the males that were recruited into care were at late stage of the disease. So first is health-seeking behavior, and entry into care is late. Females have more opportunities to get tested compared to males in this country. There's a Well Women Clinic. Sometimes maybe in pregnancy they have an opportunity to test for HIV, which is not similar to males. And looking at the HIV impact survey, up to 80% of male had not tested for HIV, however they had high sexual behavior risk in that population. This is adolescent male, according to the previous HIV impact survey. So yeah, and another thing is poor engagement in clinic, as just being adolescent men or adolescent boys by the virtue of being an adolescent male. Thanks.
Okay, thank you very much, Dr. Mariam. Gertrude?
Thank you very much. I concur with what Dr. Mariam has said about the first question, the health-seeking behavior. But also when we think of adolescence itself, it's a period of a very complex socio-cognitive behavioral development. And thinking of the gender roles that males do assume once they get into adolescence, they don't tend to open up easily. They don't tend to want to engage in areas that they get, like coming to clinic very often. So we see a lot of neurological failure and loss to follow-up among males as compared to females. And unfortunately, this goes on to adults. Even data that has looked into adults find poorer treatment outcomes among males than female. Also adding on to the multiple opportunities and avenues that females do have to get tested. And thank you for the second question of looking as adherence as a proxy to viral suppression. I agree very much. This is a proxy that can be used every visit, but is it a working proxy? That's the question that we had. And I agree with you that we're supposed to look much further into more ways that we could ascertain if the drug is working or not, because it's not really only adherence, although optimal adherence is one of the very key determinants of whether one is going to be virally suppressed or not, or even proceed to develop further complications such as drug resistance mutations and issues with drug metabolism if they were not adherents at the time they were starting their treatment. So yes, we have other studies going on looking into this. And for the mutation, our findings are similar to Dr. Joan's studies. We have a lot of mutation to the NRTIs, the M184V, K64R for tenofovir, the TAMs, and also the common mutations for the NRTIs. Good luck, it's phased out from treatment now. But we're supposed to get ahead from the problem instead of us waiting to find ourselves with drugs that aren't working, adherence assessment that is not working, and then we're found with no means to really keep our adolescent into working treatments. And we're also looking at the correlation between drug concentration in the hair to viral suppression, but that's not a method that can be quickly adopted into all the clinics in the country. So saying things like, let's use more than one adherence assessment method instead of just one, is really something that will not really require a lot of more resources for it to be implemented on top of the single assessment methods that's currently going on. Thank you. We can discuss further.
But I will give a special opportunity to Dr. Bundala from the Ministry of Health. I think you want to say something. I know you have been touched.
Yeah, thank you very much, Professor. Professor, our previous CMO, and all the participants here. Just a few to make like clarification, but at least to talk in a policy lens what have been said during this meeting. As it was introduced, that we currently have the new department named Directorate of Reproductive, Maternal, and Child Health, where I am now the Assistant Director looking the newborn, child, adolescent, GBV, and violence against children. So as you can see, basically we have a number of issues to do in that area. And basically during this learning, this post basically have been promoted just 2 months ago. So there's a lot of to learn and coming up with the focus where we need to go. The only things I wanted to say from the Ministry of Health lens, basically we do appreciate the evidence generation activities like the research. Because as we are talking about the policy, we need to set the policy. We need to formulate the policy, to implement, but to monitor. Basically, we cannot set the policy without evidence. And this is the way you need to get the evidence to make the policy the sound policy. It came one of the comments that how do we make sure these evidences come to be implemented? I think one of it we need all of us to see how we can improve this one is to think, how do we make the engagement of these policymakers from the beginning, the way we design our research, the way we analyze, but making sure that in a way they are being involved like co-investigators in our researches, so that at the end, it's not just we just come up with a recommendation asking for them to incorporate or to adopt within the policies while the involvement have been very slow or have not adequate from the beginning. I think this is the homework we need to go with it. And the second is about this implementation, and basically just the same month I was given this post, I even think I remember calling Maria and the other colleagues saying, I think we need to have a stakeholders meeting talking about the issue of the newborn, child, and adolescent, so that at the end, although we are different groups, but at the end, we need to come up as a one nation, a common and sharpened focus toward these areas. And we are thinking towards end February or early March, we have these stakeholders where we can discuss and agree by understanding what is happening, who is doing what, to what extent, what volume is really needed, so that at the end, we have one as a common sharpened focus as a country, as a nation, that these are issues we need to focus going forward. That's what I just wanted to transfer. Thank you so much.
All right, congratulations for being appointed to a challenging post. In view of what has been presented today, certainly this will be a very challenging responsibility. But I think I should assure you, as far as the researchers are concerned, as far as universities are concerned, you can count on them. Yeah, the question whether you should always be included as an investigator, that is something else. But at least we'll plead with you. When we give you evidence, make use of the evidence. Okay? Right. So, ladies and gentlemen, if I may, can I kindly request that you give a round of applause to our presenters for very good work. And I thank you very much for being part of this exciting session. I think the obvious take home here is we need more engagement and more discussions on the way we should tackle HIV in adolescents. It remains a thorn in the flesh.